Good afternoon. Good afternoon. And welcome to December's Medical Monday. We're so happy that we have a lot of people that come all the time, as well as a lot of people from our Parkinson's group came to visit today. Today is provided through the Parkinson. We received a grant from the Parkinson Foundation to talk about Parkinson's disease, and we're excited that we have one of our newest physicians, Dr. Andrew Spoljaric, and we got to meet because also he's on Let's Talk Together with me, and now I'm going to turn it over to him. So, Dr. Spoljaric.
Thanks, Sherry. Hi, everybody. I usually talk pretty loudly, so I don't know. Hopefully y'all can hear me, and I'll kind of mix and mingle around the room as we go too. My name's Andy Spoljaric. I'm a native-born Hoosier. I was born in Hammond, Indiana, raised up in the region, and Hammond people, woo! So I went to Munster High School and went to Wabash College in Crawfordsville, Indiana, and then to IU Medical School. Yeah, heck yeah. And then did a residency at IU, and after that I went into a private practice group in central Indiana, north central Indiana, and I practiced in Kokomo for the last 22 years. Yeah, it's been running around. It's been good. It's been good. And my wife and I have decided we're going to move on to our next our kid grew up and left the house, and so we decided we want to move to the country. We moved down to Liberty. We're building a house that one day will be done, and we'll move into it, and it's going to be nice. And but in the meantime, I'm loving Reid, and I'm glad to be here, and I thank you all for coming. It's great to see such a good turnout. It's wonderful, and I'm glad Reid does this. It's important stuff to reach out to the community and share information and keep everybody in the loop together. Today we're going to talk about Parkinson's disease, I don't want to brag about my clinical acumen, but I've seen a few people in the room today with Parkinson's disease, it's a very important thing, and it affects our community in a big way. And I'm hoping to share some information. I hope I share useful information, and if I get too far afield and you guys start to glaze over, I'll go to the next slide. So the first thing we're going to talk about, what is Parkinson's disease? Well, Parkinson's disease is what we call a neurodegenerative disorder. And a neurodegenerative disorder basically means that there's something in the brain that goes awry, and it starts to degenerate in its function, so it no longer works as efficiently as it used to, and that's where the degenerative term comes from. And in this case of Parkinson's disease, it's what we call a movement disorder. And when I started training Parkinson's disease, all we talked about was tremor, and we talked about walking and balance. And now we know there's a lot more to Parkinson's disease than walking and balance, but we still think of it as a movement disorder. You'll commonly hear it referred to as a movement disorder. And for folks that have Parkinson's, you may see a movement disorder specialist if you go to Cincinnati or IU or places like that where they have specialized neurologists who just do Parkinson's and related disorders. They're called movement disorder neurologists. I'm a general neurologist. I treat Parkinson's disease. I spent a lot of time with movement disorder specialists, but I'm not a movement disorder specialist per se. I don't have that certification or training. None of us do in our practice here. But most neurologists don't, I guess is what I'm trying to say. Parkinson's was first described in detail by Dr. Parkinson. Imagine that, in 1817, an essay on the shaking palsy. And so it only took 133 years for us to figure out what caused it. And this Swedish pharmacologist, started to figure out there's something in the brain called dopamine, and dopamine seems to be an important thing. And the research that Dr. Carlson did helped us to figure out that if we use this medicine, or this compound called reserpine, that we could deplete dopamine in the brains of mice or people. And then we could look for things that might, and those people develop the signs and symptoms of Parkinson's. And if we gave them different compounds like levodopa, their Parkinson's symptoms actually improved. And so if you've not seen the movie, strongly recommend it. It's called Awakenings. Robin Williams is in it. Great movie. It talks about the original introduction of L-Dopa to nursing home residents in the 60s. There was a lot of post-encephalitic Parkinsonism after the big flu of 1918. There was a bunch of folks sitting around nursing homes in the 60s with untreated Parkinson's because we didn't have any treatments. So they were stiff and rigid and couldn't do much. And we started to find medications that could help. And so that's a great movie. In 1980, there also was an outbreak of Parkinson's disease in otherwise young, healthy people that didn't make sense. As we know, Parkinson's is more common in folks as we age. We'll come to that later. But in the 80s, there was this designer drug called MPTP, and it created a new model of Parkinson's disease. You give people MPTP, and they develop the signs and symptoms of Parkinson's disease. So and so that was another way that we could give animals Parkinson's disease and then try to treat them so that we could figure out what works for this disease. So it's about 1 to 2 people per 1,000 in the general population. It increases with age, and it's about 1% of the population over age 60. And you can see it dramatically increases with age, the prevalence does. It's about 3 in 1,000 people between age 55 and 64, which is pretty rare. And it's 3 times more common between 65 and 74. And 3 times more common still between 75 and 84. And then half again more common between 85 and 94. So it's definitely, the older we get, the more likely we are to see Parkinson's disease for sure. And men are about 1.5 times more likely to have Parkinson's than women are. So what is Parkinson's? How do we know Parkinson's? And if you ever see me in the office, I'm known to say Parkinson's is like pornography. You know it when you see it. It's got a very characteristic appearance to it. And the tremor is usually in the beginning of the disease unilateral, and it's a coarse tremor. And it's a resting tremor. So it's much more noticeable when your loved one is sitting on the couch watching the boob tube, their hand may be shaking on their lap, than if they're at the dinner table eating food. They won't really shake much for that. We briefly touched on essential tremor versus Parkinson's tremor. So Parkinson's tremor is this coarse resting tremor, usually unilateral, but later in the disease will become bilateral. But essential tremor, which is, I see a lot of anxious people that come to see me and they think they have Parkinson's, and what they have is essential tremor. Essential tremor is not great, but it's a little bit easier to deal with than Parkinson's for sure. Essential tremor is this kind of tremor. And it's where your hand shakes if you drink too much coffee, if you're nervous in front of a room full of people, or if you have essential tremor, then your hand will do this. And it's worse if you're drinking your tea or your coffee. And it's better when you're relaxed. Sometimes people will drink a beer or wine and they notice that calms down their essential tremor as well. That has no effect on Parkinson's tremor. So the tremor is the first hallmark of Parkinson's disease. And the second one is what we call rigidity. Rigidity is stiffness. And I'm 53 years old. I'm definitely more stiff than I was when I was 33 years old, but it's a different kind of rigidity. And you'll notice it's a cogwheel rigidity. It's almost like, if you know what a ratchet is, like a wrench that you ratchet and you tighten, it goes rip, 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 and the ratchet's back and forth. And there's a ratcheting characteristic to the stiffness in the muscles. Akinesia or bradykinesia. Akinesia means no movement, and that's not really accurate. Bradykinesia means slow movements, but reduction of movements. And so your folks with Parkinson's disease, you'll see they don't move as much. They don't have as much facial movement. They just sitting when they're talking to them, they don't move as much as their spouse next to them. You can literally see the difference. But that's part and parcel, or that's one of the characteristics, motor symptoms of Parkinson's disease. And then postural instability. And what that means is One of the other terms we use is impaired righting reflexes. So in other words, if you start to fall, you have a harder time catching yourself. And that's kind of the characteristic of the imbalance difficulties with Parkinson's. If they start to fall, they tend to fall like a tree. They don't tend to catch themselves very well at all, and the falls can be quite serious as a result because we're not very good at catching ourselves. I've seen a lot of folks with Parkinson's, though, that fall like champs. I tell you, they've learned how to fall, and they've fallen for decades, and they don't get hurt. I don't know how they do it. It's amazing. It's a tricky disease. And those four things, tremor, rigidity, akinesia, and postural instability, is this trap of Parkinson's disease that I always tell folks about. There's other motor symptoms too, though. There's a particular gait pattern, and the gait pattern that we see, gait means walking. What does it look like when you walk? And people with Parkinson's tend to have a stooped posture. The shoulders tend to roll in, and they tend to take little tiny steps. And that's kind of your characteristic gait of Parkinson's disease. And there's also diminished arm swing. It's a characteristic because this is what's affected by the disease. These dopamine pathways to these motor structures in the brain uniformly are affected, and they cause these patterns. Dystonia is another thing that's more commonly associated with medications, but is still also seen with Parkinson's sometimes, and it's an abnormal muscle tone, where the muscle goes into an abnormal posture and is stiff or tight, and that's part of it. People with Parkinson's tend to talk softly. They tend to talk really low. They don't have a lot of projection to their voice, and they don't talk from their diaphragm. And when they see a speech therapist, the speech therapist will teach them, talk from your diaphragm. But that's not, the brain doesn't automatically do that like it does automatically for the rest of us. Drooling's a very common problem. Difficulty swallowing or dysphagia is another common problem. Fatigue, and then this terrible thing called akathisia, which is a subjective feeling that you need to move. It's very unpleasant. It's not that you have to move, but it feels like you have to move, and it doesn't go away. You can treat it with medication, but it's also one of these motor symptoms of Parkinson's. But there's also non-motor symptoms, and it's interesting. In my 28 years of medical practice, since I got out of medical school, God, that's a long time. It's amazing how much stuff we've learned about, and we've learned, realized, appreciated is attached to Parkinson's disease. 20 to 80% of folks with Parkinson's will suffer with depression. And caregivers are also up there too. Thinking problems. We know that some folks with Parkinson's can develop memory problems or even dementia, which is a more severe memory problem that means that the person has diminished ability to carry out their own personal care needs. But they also sometimes have delusions where the folks will believe things that aren't necessarily true. And they also may have hallucinations where they see things, most commonly see things, but sometimes hear things or smell things that aren't actually there. And up to a third of people will have those problems with their Parkinson's disease. An impaired sense of smell actually may predate the Parkinson's diagnosis by a decade. There may be diminished sense of smell 10 years before you ever get diagnosed with Parkinson's disease. And people with Parkinson's tend to be sleepy. They want to sleep more during the day. They don't sleep well at night, and their sleep is fragmented a lot of times by movements and jerking and these sorts of things at night that really makes it difficult to get a good night's rest. Also, there's this thing called seborrheic dermatitis where you get these kind of thickened, oily skin spots that goes along with Parkinson's disease. A lot of times it's on the forehead or in the hair. Weight loss, difficulties controlling your bowel or bladder, constipation. Again, constipation can precede the diagnosis by decades, and drooling can also be a non-motor symptom, or motor. I guess that's under both. That was on both slides, wasn't it? So, questions about this? Anybody want to ask anything before I move on to talking about Parkinson's versus Parkinsonism? No? You're all with me?
What is Lewy bodies?
Lewy body So a Lewy body is a anatomical little thing you can see under the microscope. Technically, Lewy body disease or Lewy body dementia or diffuse Lewy body disease is actually probably the best name, implies more, there's these abnormal, so this Lewy body is the unit of pathology. So this is in the brain of people with Parkinson's disease, and it's not in the brain of folks without Parkinson's disease. Okay, so this is the thing that we say, aha, this tells us this was the brain of a person with Parkinson's disease. You can't see it on a scan. You actually have to see it on a brain that's autopsy specimen and under the microscope. So diffuse Lewy body disease, again, one of my favorite actors, Robin Williams, same guy that was in Awakenings, diffuse Lewy body disease. He just died from that. It tends to affect younger people. It tends to be much more psychiatric originally, early on, hallucinations, paranoia, delusions, these sorts of things. Some Parkinsonian symptoms, maybe the tremor, maybe the walk, but maybe not the whole constellation of the Parkinson's thing. And it tends to be much less predictable, much less treatable, and it fluctuates a lot from day to day. So that's a diffuse Lewy body disease, and you wonder, well, why do we call it that? Because in regular Parkinson's disease, particularly early on, you see these Lewy bodies only in particular areas of the brain. It's not diffusely all over the brain. It's just in this part of the brain called the substantia nigra that we'll come back to in just a minute. But so that's what Lewy bodies are. It's a whole thing. It's a complicated thing, and there's a lot to it. I could talk for hours on that diffuse Lewy body disease. If that, maybe I'll come back and do that sometime. But so Parkinson's disease, idiopathic Parkinson's disease, is the correct name, if you will, for the ICD-10 code of what we're. If we tell you or your loved one that you have Parkinson's disease, we're talking about idiopathic Parkinson's disease, meaning we don't know why you got it, but it looks like Parkinson's, it acts like Parkinson's, it's not anything else that we can rule out, and it responds like Parkinson's disease. Really, that's kind of the nuts and bolts of it. It's a clinical diagnosis, and I'll come back to that in a minute. But then there's other things that look like Parkinson's disease, and those things are what we call Parkinsonisms. And so that's like vascular Parkinsonism. People may have a stroke or more or several strokes, and after the accumulation of strokes, they can develop a Parkinsonian syndrome where they look like they have Parkinson's disease, but it doesn't tend to follow the time course that we see with idiopathic Parkinson's disease. There's drug-induced Parkinsonism, like that MPTP stuff that I mentioned to you before, or very common stomach medicine called Reglan or metoclopramide can cause Parkinsonism. Our antipsychotic medications that we use for psychiatric conditions can cause Parkinsonism. Toxic Parkinsonism is kind of in that same as the drug-induced, but also organophosphate pesticides and these sorts of things can also cause Parkinsonism. Post-traumatic Parkinsonism, where if your head has been injured, your brain has been injured, boxers, this has been associated with boxing, can develop a Parkinsonism, doesn't respond to treatment very well at all. And anoxic Parkinsonism. The atypical, the biggest difference clinically is that this one tends to respond to all these wonderful treatments we have. These other ones don't tend to respond nearly as well to all the treatments that we have, unfortunately. So back to the pathophysiology and the Lewy body disease that you brought up. So we see these Lewy bodies, the last point on this slide, particularly in this part of the brain called the substantia nigra. Interestingly enough, there's another slide coming up in a minute, where we talk about this Brock stage. Brock is a neuropathologist who actually has developed a classification scheme for Parkinson's disease. And I'm not sure if it's a he or a she. They identified Lewy bodies in the gut and the nasal passages, tissue of people before it ever quite gets into the brain. And we think that may imply that this may be something environmental that we're exposed to at some point, either in our food sources or in our air, that actually we pick this up rather than it being something that we're born with, at least sometimes. But anywho, Lewy bodies are part of the pathological unit that we tend to see, particularly in this, in Parkinson's disease, in this pars compacta of the substantia nigra, mainly in the brainstem and the basal ganglia. And so these parts of the brain that are affected and the resultant diminished dopamine results in the syndrome of Parkinson's disease, that trap, that tremor, that rigidity, that slowness of movement, and those balance problems. Had to throw this in because you can't give a neurology talk without a pretty brain picture. So diagnosis of Parkinson's disease, how do we diagnose it? Well, actually, it's not very exciting. We talk to you and we look at you and we examine you, and that's how we diagnose Parkinson's disease. If we're not sure, then we can do something called a DAT scan, and it's as good as sending a person to a movement disorder specialist at determining whether it's Parkinson's or not Parkinson's. This CAT scan, the MRI, those things don't show us anything in folks with Parkinson's disease. If it shows a lot of vascular problems or circulation problems, it may point towards that vascular Parkinson's disease, or vascular Parkinsonism, I'm sorry, excuse me. I make that mistake all the time. But you don't expect to see anything on the CAT scan or the MRI that says, aha, it's Parkinson's disease. And it doesn't work that way. It's a clinical diagnosis. This is the interesting slide that I think is, this is a neurodegenerative disorder, and I think this is one of the things that is really telling about how these things work. So on this slide, and this thing doesn't really work, over here on the left side, so this little circle in the middle and that arrow going down, that would indicate that's when you're diagnosed, that's when you start having symptoms of Parkinson's disease, is right smack in the middle of that line. The left half, and the 20 years before a person is diagnosed with Parkinson's disease, there's other stuff going on. There's Lewy bodies in the gut and in the nose and in the 10th cranial nerve. There's Lewy bodies in this basal brainstem region. And then there starts to be Lewy bodies in the substantia nigra and these other parts of these basal ganglia structures that we talk about that are affected. And then as it progresses on, it starts to look more like diffuse Lewy body disease because it's all over the place by the time a person has Parkinson's disease for 20 years. And that may be why, phenomenologically, late stage Parkinson's has some similarities with Lewy body, with the hallucinations and the delusions and the psychiatric manifestations. Yeah?
So is that a pretty solid number, 20 years before?
20 years from the time you're diagnosed till the severe disease tends to be, or from the time you start having symptoms to the time you have severe disease is more, this 20 is more predictable than this 20. Yeah. Yes?
You mentioned drug-induced Parkinsonism. Is this associated with chemotherapy?
Well, that's a good question. I am not aware of any chemotherapy agents that have been, I'm not aware of any chemotherapy agents that have been associated. It may be a toxic, so like platinum, cisplatin, Taxol, some of those chemotherapy agents can be pretty toxic stuff in general, and it can cause neuropathy, it can cause vision loss, it can cause all sorts of different sort of nerve things. And so in that sense, it's not unreasonable that you could have some Parkinsonism from chemotherapy, but I'm not aware of any chemotherapy agent that we say, oh yeah, and there's a 2 or 3 or 5% chance of developing Parkinson's disease as a result of it, or Parkinsonism. It's really more so the antipsychotic type medications. Even antidepressants can sometimes cause Parkinsonian symptoms, nausea medications, those kind of things that are much more likely to be associated with drug-induced Parkinsonism, sorry, excuse me, I do that all the time. Feel free to slap me if you get tired of it. So this is interesting. So the idea being that this neurodegeneration has started decades before we ever get diagnosed. This is also something that you're going to see mirrored in our where we're going with Alzheimer's disease right now. Alzheimer's disease is a similar but different, very different neurodegenerative disorder that we're starting to pick up on the fact that there's changes going on neurochemically in people for decades before they start to manifest the disease. It's one of those things that this Brock stage, this 1 through 6, like I say, that's the part that I think is so curious, that we can see Lewy bodies in the gut and in the nerves that go to our nose 20 years before we see Lewy bodies in the brain in folks with Parkinson's disease. So then there's these kind of nasty ones called Parkinson's plus. Parkinson's plus, I threw it in there only because one of the things, I have had many patients in 28 years of doing this, and a couple of folks, they couldn't grab a hold of that plus no matter how hard I tried. Every time I'd see them, they'd be like, so my Parkinson's is getting worse. I'm like, I know, because you don't have Parkinson's, you have Parkinson's plus. And then the next time they'd come back and see me and they'd say, my Parkinson's is getting worse. And I'd say, yeah, I know. You don't have Parkinson's disease, you have Parkinson's plus. It just didn't. And sometimes that just happens, and it's not good. But Parkinson's plus is not Parkinson's disease, okay? It's different. The big one, impaired vertical gaze, meaning you literally can't look up or can't look down. Your eyes just don't do that. And if your eyes don't do that, and you have other signs and symptoms of Parkinson's, you probably have progressive supranuclear palsy. And progressive supranuclear palsy is tough stuff. There's no real effective treatment. It tends to get worse a lot quicker than 20 years. And people tend to either die from falls because of severe stiffness and severe walking problems, or they choke on food and can't swallow. And it's a bad disease. There's another one that's called multiple system atrophy, and this is where people have a lot of terrible incoordination and their blood pressure bottoms out, and they'll fall out. And the low blood pressure can happen with Parkinson's, but when it's really severe, that's called multiple system atrophy. And the third one is where there's a lot of weird brain stuff, for lack of a better term. Stuff like alien limb phenomenon, where your hand just kind of does what it's going to do despite your best efforts to control it. Or inability to, people lose their ability to do complex tasks, even though they are physically adept, they have coordination and can do things, but they can't open a can of soda, or they can't open a door, or they can't brush their teeth, or they can't figure out how to put a fork in their mouth. And so they have these other sorts of higher functioning deficits superimposed on this Parkinsonian syndrome, and that's called cortical basal degeneration. Again, these are particularly gnarly because they don't respond to treatment, and they tend to be more severe, and they're very hard for not just patients but families and caregivers. But we have good treatments, a lot of treatments for Parkinson's disease, and so all is not lost. I don't want to get wallowed down in the negatives here. Parkinson's disease, which again, going back a couple slides, most common cause of these Parkinsonian syndromes is Parkinson's disease. And we have lots of medicines, and I'm going to come to those next. And in people who have Parkinson's, we got lots of medicines, right? I always tell people, if you don't like taking pills, you got the wrong disease, because we got lots of pills. Surgical treatment is also a thing. Surgical treatment in 2024 is at places like IU and University of Cincinnati and these kind of tertiary referral centers where they have neurosurgeons who are specially trained in these complex surgical procedures to put deep brain stimulators and these sorts of things in, and they can be remarkably helpful. Exercise and rehab is so important for Parkinson's disease, and I'm so glad that Liz is going to talk more about that and the Rock Steady Boxing and that program, because it is every bit as important as taking pills to get exercise, to keep moving, to keep doing things. If you want to keep moving, you gotta keep moving. That's all there is to it. You can't get there just taking pills and hoping it's going to get better next week. You got to keep moving. You got to keep working at it. Education, this is what we do. We teach people what to expect with this disease, what not to expect with the disease, and it's not going to go away. The pills aren't going to make it go away. The pills are going to make it easier to do those day-to-day things that are a challenge. That's the goal of those to treat the symptoms, so the tremor is not so noticeable, so that the walking is more safe and more steady. Nutrition is really important because, like we talked about before, folks with Parkinson's tend to lose weight. So we got to make sure they're getting adequate nutrition. And then psychiatric counseling for not just patients, but also families and their doctors. Treatment of Parkinson's disease, we got lots of pills. The gold standard is carbidopa-levodopa, that same thing that Robin Williams gave his patients in that movie in 1967 in The Awakenings. Same stuff. It's still the gold standard. We use more of that than anything else for Parkinson's disease these days. It's cheap and it works. It's the best kind of pill there is. There's also different medicines like MAO-B inhibitors and COMT inhibitors, and you can see their names listed there. It's a word salad. I don't want to just sit here and say lots of long names. That makes me stutter. But those pills are to basically keep the dopamine around longer. I always tell people carbidopa-levodopa is like force-feeding your brain the ingredients it needs to make dopamine. So then your brain can make dopamine. Now, how do we keep that dopamine around? We use things like MAO-B inhibitors or COMT inhibitors to prevent the breakdown of that dopamine. And so the basic medicine is that carbidopa-levodopa. Dopamine agonists are also used, and sometimes they're used first line. I've never used them first line. The people I trained with never used them first line. But some neurologists I know do use them first line. Things like ropinirole or Requip or pramipexole or Mirapex, rotigotine, which is called Nupro. It's a patch. Apomorphine is an injection. That one's never used first line. But those medicines also kind of supplement the treatment. So we usually start off as simple as we can, and then as the disease gets harder and harder to treat, we tend to stack these additional medications in to try to counteract where people are struggling and to try to figure out where there's gaps in their days. Where do people, are you good all morning, but then the afternoon's not so hot? So moving doses around and picking different medicines. And then there's this interesting phenomenon we can do in Parkinson's where we can adjust a different chemical in your brain called acetylcholine to make your brain think it's got more dopamine. So we can block this acetylcholine. But those medicines tend to be problematic because they can cause difficulties with memory and stuff, and that's not good when you're talking about a population that's already, most of them are 65 and older. So deep brain stimulation is the surgery, like I said before. But there's lots of treatments, and I didn't even get into the non-motor treatments, and I should have mentioned that. There's a medication that's now approved for treatment of the hallucinations and the delusions that are associated with Parkinson's disease. It's very effective. It's something that everybody should know about. It can make life a lot easier for everybody. Treating the depression, there's no magic things there. We just use the same sort of depression or anxiety medications we would use in anybody else. And then, of course, all the other normal stuff that folks get, blood pressure and diabetes and all those kind of things, those are treated the same way as they always would be, Parkinson's or not Parkinson's. Some of the resources, how am I doing on time? Am I running? Okay, cool. With Parkinson's disease, there is, I think there's no amount of thanks that would be too much for us to give Michael J. Fox for bringing this into normal stuff. This is just a thing that people have, just like anything else. It's not anything difficult or scary or shameful or these kind of things. It's just another disease that folks get, and it's another thing that we need to know about and we need to learn about. and he's done wonderful work. And Parkinson's Foundation and American Parkinson's Disease Foundation, Indiana Parkinson's Foundation were wonderful organizations. Rocksteady Boxing, and Liz is going to talk with us a little bit about that here shortly. It's a wonderful program for specifically targeting folks with Parkinson's disease, and Muhammad Ali was instrumental in bringing that into the existence, and his contributions also tremendous to this, bringing this disease into the fore and letting us know that there's things we can do about it. The National Institute on Aging has a lot of information, so if I always put that name on here, because if you or a loved one have a diagnosis of Parkinson's disease and you want to know what's going on with Parkinson's disease, that's a pretty good place to look. It's got a lot of information. Anything that's reasonably evidence-based, there's information on their website about that. Yes, and so at this point, I will turn it over to Liz, and she's going to talk to you about or maybe I should take questions first. I should take questions first, yes.
Is Parkinson's and Lewy body both inherited?
Not very much. And that's a total cop-out. You're like, why does he say that? So there's certain patterns of inheritance, and there's a condition called Huntington's disease. I saw a young lady with that disease this morning. You got a if your parent has it, you got a 50-50 chance of having Huntington's disease. And so this is not like that. So this is not like that at all. Having multiple family members with Parkinson's disease may increase your risk of having Parkinson's disease. And you notice I said may. It doesn't necessarily increase your risk of having Parkinson's disease unless you're a member of a few families that have been identified with clear-cut familial Parkinson's disease. Those are mainly Japanese families that have been identified as having this really familial form of Parkinson's disease. So probably not. Lewy body, I don't believe so. I don't believe that there's a real strong genetic link there either. No problem. Like I say, when I was in college at Wabash back in the early 90s, I did genetics, and genetics back then, a lot of it was Mendelian genetics, which is like green peas and yellow peas, and mix them together, and you get green peas and yellow peas and green yellow peas, and so it was simple genes. Then since then they've cloned a sheep, and we've mapped the human genome, and we realized that there's not just genes, but there's also these things called epigenetics, which is not just your genes that you have, but how does your body deal with those millions of genes, and how do they stack them up, and how does it store them, and how does it hide them, and how does it activate them. And so genetics is incredibly complicated, and like I say, so it's not like you can say there's a 10 or 15 or 20% chance of having Parkinson's with it, but there may be an increased risk, but it's not so great that you should lose sleep over it. That's the way I usually talk to folks about it. Yes?
The Michael J. Fox Foundation in April of last year said that they found a new biomarker for Parkinson's. Can you explain that to me?
So Michael J. Fox said they found a new biomarker for Parkinson's disease in April of last year.
Yeah, and I didn't understand what that meant.
That's a good question. I'm not 100% sure exactly. I remember that article. I remember that something came out about that. I read the blurb. It was in like Science Times or one of these sorts of these throwaway magazines. It was I believe what it was is it was something that they were going to look at it more and determine how well it correlated. I think there was there's some early on data that was saying that we were seeing this an increased number in people with Parkinson's disease, but there was going to be more research needed to figure out what it meant. And I think that's where it's still at, because I've not heard of any blood tests or urine tests or these sorts of biomarkers in general are things that we can use as a marker of a disease. I think probably one of the best things that everybody may well have heard of, hemoglobin A1C. Okay, that's a great one. That literally measures how many of your hemoglobin molecules have sugar stuck on them. Okay, and that tells you on average what your blood sugar has been doing over the last 3 months. That's a great biomarker. That's a great test that you can say if your hemoglobin A1C is 10, you got diabetes. That's all there is to it. And so that's a biomarker, and it makes our job easier because we don't have to think about stuff. We just order a test and then boom, it comes back and yeah, you got it. And then we know how to, we can treat it like that. These diseases, we don't have that yet, as far as I know. The closest thing we've got is this DAT scan that actually shows this different pattern on the scan, but they're looking for it.
So we can hear back here. Thank you.
They're looking for biomarkers, and that's the thing. Because, like I said before, there's not neurologists in every county in Indiana, and it's hard to get in to see neurologists. And so if your primary doc can order a test, when you show up and you think, goodness, this person might have Parkinson's, if you can order a test and say, yeah, it's Parkinson's, then, that's obviously important. That test doesn't exist yet, but it may be coming.
I have another question.
Yeah.
I'll use my cheat sheet.
Sure.
Peter Tass, PhD, he's a professor of neurosurgery at Stanford. He's working on a vibrotactile glove thing. I'm not, it says neurosurgery gloves. I've seen them and they're having good luck with them. Why is it taking so long to get these out to everybody so that they can use them? There's no medicine involved. It's not anything, I don't know what we're waiting for.
There's a lot of crap that people put out there, quite frankly, because they say here, I made this pill, I made this supplement that's going to cure your Parkinson's disease. And people with Parkinson's disease will be like, yeah, I'll take it. Well, the FDA has rules. They have to prove it works. That's one of the biggest things. And so I'm guessing these gloves, and I don't know anything about them, I'm going to be completely honest with you, but my guess is they're going through some sort of FDA testing right now to see if they actually work. And that
they had to adjust you have the electrodes on every finger.
Yeah.
And there's a certain pulse that they have found that it has to be synchronized a certain way for it to work.
Yeah. It's fascinating. I mean, this is how breakthroughs happen. I have not heard anything about them, but it's like another one is stem cells. Okay, some people are all about stem cells. Other people are like no stem cells. But anyway, regardless of what you think about them, they may be magic, right? If you can put cells in there that will fix this whole Lewy body thing, well, that's a win, right? There's no question about it. But I have to go over there because I think I'm done. But so I don't honestly know the answer to those things.
What about the infrared helmets that they've had good luck with, but they're not on the market yet?
Right. Those are supposed to grow hair too. Yeah, right. And again, it's another example, just a real quick example. If you guys have heard of Neuriva, and I hope I'm not going to get sued for this, Neuriva is a supplement that they sell because it helps you brain better. What does that mean? Okay, but that doesn't mean anything. That's what they can say officially on their commercials. They can say it helps you brain better because it doesn't really mean anything. The studies that they do a lot of times are not very well controlled, and they don't show definitively that these things work. They have to do a study that's controlled, and somebody on the outside looking in makes sure they're not cheating. And that's the biggest thing with a lot of these miracle cures that you read about on the internet, is that there's nobody that's actually secondarily looked over these. Now, maybe they're going to be fantastic and awesome, and I'm not diminishing the questions at all, but you have to look at these things really carefully and the data that you read, because if it's something that that I decide, these gloves are awesome, I love them. I had 3 patients and they worked on all 3 of them. That's not science. Okay, that doesn't mean it's going to work on the next 3 or the 3 after that. So it's just really important to try to find and these. it's important if you have this disease to get involved in clinical research. Get involved in research at places like University of Cincinnati and IU where they're doing research like the glove guy. And you can get on clinicaltrials.gov. It's a clearinghouse that you type in Parkinson's disease, type in how far are you willing to travel, and you can get enrolled in that guy's glove study. It's that easy. You can find the information. You can do all these different things. And for diseases like these that we don't fully understand, that we don't have cures for, that's how it happens. People have to get in there and do the science. And some people that have a tough disease and their life is already challenged by this have to get out there and do more crap and go sit in a waiting room at some university while a med student pokes them and prods them and they do research. But that's the best I can say about, what's available out there as proven versus what's potentially available out there. But I would, reach out to these people and find out what you can do and what you can. Yes.
Another quick question: since male have a higher rate than female,
Yeah.
is there a hormone imbalance?
Right. I guess the question that we would ask, does estrogen have some sort of protective effect? And it might. We don't honestly know that. Or is it something else that us dumb guys are doing that gives us this more often? That's the other side of that coin. And so who knows? But it's a very interesting thing, and we don't know why that is. We don't know why that is, quite frankly. It's a very good question, and the primary research types are looking at that and trying to figure that out, because that obviously is an important piece of the puzzle. No problem.
Thank you.
Thank you. Thanks, everybody.
But we are pivoting just a little bit, and Andrew Hoover is going to talk to you about rock steady boxing. So first we're going to play a video that a lot of our boxers are actually in. So it's just 1 minute long, just a minute, and then Andrew will quickly talk and we'll get you out of here. Sound good?
All right, can y'all hear me? Yeah. Awesome. So my name is Andrew. I'm part of our community health team, but I have the awesome part of my job is I get to be a quote-unquote volunteer coach. I'm paid for it, but I'm a volunteer coach. Don't tell my boss, but I'd probably do it for free. I get to be part. I get to be part of the Rock Steady boxing classes at least every Friday. But this week, actually 2 or 3 times this week. So myself and Nathan and Ashley back here, we all are volunteer coaches. So is Jesse in the back. But then Liz and Brittany and Matt, you guys some of you heard from Matt a couple weeks back, are actual certified coaches with Rock Steady. But it is an awesome program. So we're going to suffer through this. I've not seen this PowerPoint slide, But if I have questions, I'm going to ask Liz. And if you have questions after the class, feel free to ask, and then Liz or Jesse or myself can answer questions for you. So Rock Steady Boxing, Dr. Spoljaric, did I say that right?
Yeah.
Okay, kind of mentioned a little bit about this. So Rock Steady Boxing is a form of physical exercise for individuals who are living with Parkinson's disease. It's a non-contact, boxing-based exercise program that can improve an individual's ability to live an independent life while battling Parkinson's disease. And quote me if I'm wrong on this, but Reid is the first hospital in the country to ever bring this program. Usually you see this at like gyms, like community gyms, fitness centers, YMCAs, things like that across the country. Years ago, Reid was the first hospital to actually bring this to their hospital. So that's pretty awesome. So it is appropriate for anybody who's diagnosed with Parkinson's disease. So if you have Parkinson's disease, you qualify for Rock Steady Boxing. It is something that you would need to talk to your doctor about, Dr. Spoljaric or any of his team members, your primary care physician, and then they will contact the fitness team to try to see if they can get that referral started for you. The caregivers are also encouraged to attend the class. So if you have a caregiver, they're encouraged to attend the class with you to learn more about Rock Steady Boxing and the fight that their boxer is going through. There's also a couple other things when your doctor does refer you. There will be a release form and things like that to make sure that the patient is safe while doing it. So why boxing? All right, so recent studies suggest that this type of exercise may be neuroprotective. It actually slows the disease progression. And a cure may be years away, but Rock Steady Boxing has demonstrated that anyone can lessen their symptoms and lead a healthier, happier life in all stages of Parkinson's. Boxing moves the body in all planes of motion while continuously changing the routine as you progress through the workout. So as we continue on, you'll learn more about some of the workouts that you saw on the TV. I know we have plenty of our boxers out here too that would love to answer any questions for you as well. Some of them just got done working out this morning. Some of them ditched class so that they could come here. So the advantages of Rock Steady Boxing, there are plenty. So the focus is, it works on that gross motor movement that we heard about, your muscular strength, your muscular endurance, your balance, footwork and agility, movement accuracy and rhythm, hand-eye coordination, and fine motor skills. The benefits? One, it creates peer support. We have close to 30 or 40 boxers a week at least? More than that come out. And they come out, they see each other. You can ask any of them in the room. I know they all get together, they talk, and they're able to kind of build that community together. Increased respiratory strength. Sometimes they come and they're out of breath. They got that helps with that. Improved mental focus and reaction time. Improved, that's a big word. What they just said. Posture and balance. Development in strength, speed, power, and endurance. Increased flexibility, stress relief, and improved quality of life. So the benefits of exercise. Forced or voluntary exercise can induce psychological change in the brain. Exercise is proven to be neuroprotective. Intense exercise can slow or reverse that motor decay, the need to increase drugs, quality of life problems, balance problems and falls, caregiver burden, cognitive declines, and depression. So all these things are things that are worked on in class. Just today, some of our boxers are working on dexterity. So working with their hands and their brains to do crossword puzzles, things like that, to work different parts. Sometimes we run, sometimes we work on weights, sometimes we box. Sometimes it's just a matter of balance. So lots of different ways to work your brain and your body. So class design. Each class is designed and led by a Rock Steady Boxing certified head coach like Liz. Rock Steady also utilizes volunteers and assistant coaches. So assistant coaches go through a little less training than some of the actual certified coaches, and then the volunteers, we actually all go through training as well and get certified. So lots of things. All the coaches are trained in what to look for in Parkinson's, what does a fall look like, all of that stuff. Exercises can be modified or Alternative exercises can be recommended to accommodate each individual's needs. Every boxer has their own needs, their own progression. They're all at different stages. So that's something that's taken into account. There's a workout that we do every week, but accommodations can be made. If a boxer can't do a full jumping jack, can we go out like this and just come back in? It's all working with their needs and where they're at. Class focuses on overall fitness while addressing the neurospecific needs of the Parkinson's individual. So we work on lots of things you'll see in your gyms. So heavy bags, speed bags, double bags, focus mitts, free weights, resistance bands. We work on cardio, core, dexterity, and voice work. One of the things we like to do is, it's one of my favorite things, is we'll do things where it's like you got to punch a punching bag and then you got to quack 3 times. It's goofy, but we got to get people talking, get people screaming. A lot of our boxers will know there's a lot of yelling rock steady, so that we're using our voices in different ways as well. If you come to boxing and you are someone that has Parkinson's or someone you know, new potential boxers receive an initial assessment at no cost to determine what specific level of class they should be assigned to. We have 3 different classes, and they're all at different speeds. And Liz and the other coaches will do that assessment with you to figure out which class is best for you. It's a great opportunity for the potential boxer to get questions answered that they may have about the program. And then there's some rock steady boxing assessments. So there's a Parkinson's disease questionnaire. There's also a Fullerton balance scale, a sit to stand test, and timed up and goes. And all of that's done in the assessment with your coach. And all of our coaches, I will say, all of you are like trained in how to work with people that may have balance issues, falls, and things like that. So you're with professionals they're exercise people, but they are healthcare professionals that are there to make sure that people are safe. And the gym is really soft too. So if you fall, it's not like you're falling on a full hardwood floor. There are a couple of class options. So in Richmond, we do it Mondays, Wednesdays, and Fridays. There's one at 8 a.m. to 9 a.m., 9:15 to 10:15 a.m., and 10:30 to 11:30 a.m. And in Connorsville, we do it on Tuesdays and Thursdays, all levels from 10 a.m. to 11 a.m. We do it out of our primary and specialty care office on Western Avenue in Connorsville, and out at our North Complex, which is the old Highland School, on Chester Road in Richmond. So if you have any questions, there is information there, but you can also, of course, ask myself, Liz, Jesse's in the back, Ashley, Nathan, Jess. Any of us would be happy to answer those questions. And if somebody you know has Parkinson's, or yourself, and you're not in this class, make sure to talk to your physician, whether it's your neurologist or your primary care physician, about seeing if you could get in these classes as well.
I was going to say, talking about the sponsorship in case people might not be able to afford it.
Yeah, so there is a cost to it. I don't know if we're going to talk about the cost per se on here, but there is a cost to it. But if you have trouble paying that cost, there is a scholarship available too. So that's something you could ask your trainer about when you meet with them for the assessment as well. So, any questions about Rocksteady? It is an absolutely awesome program. I think I've been doing it for about 3 or 4 months now, and it is super, super cool. It's something I look forward to every Friday when I get to do it. So.